So in CLL14, this was a randomized phase 3 trial where we randomized patients who did not receive any prior treatment for the CLL, and additionally who had a particular threshold of coexisting conditions. This was assessed by the cumulative illness rating scale that I alluded to before, and also by an impaired renal function. So patients were also eligible if they had a creatinine clearance below 70 milliliters per minute as a surrogate for impaired fitness. And in this trial, the patients were treated either with Chlorambucil-Obinutuzumab for 12 cycles as a chemomonotherapy that had been established particularly for patients with coexisting conditions. And patients were alternatively also randomized to a treatment without chemotherapy with Venetoclax-Obinutuzumab, also over 12 cycles. And the main result of this trial was that we can have a longer progression-free survival in patients treated with Venetoclax-Obinutuzumab than with Chlorambucil-Obinutuzumab. And now we've done this follow-up analysis that we've prepared now and present now. And in this follow-up analysis, we have a close look on how the depth of responses of these patients is. And what we see on the one hand is that now that all patients are off treatment, all patients have received their limited duration treatment, and now they are off treatment for at least 2 years. And we see that there is a sustained benefit of patients treated with Venetoclax-Obinutuzumab. Namely, we see that after getting off treatment and continuing to be followed up for disease progression, we see now that at 3 years, approximately 82% of patients in the Venetoclax arm did not have a PFS event. So they did not have a disease progression, or they did not die of any other cause. And on the other hand, we see in Chlorambucil-Obinutuzumab that approximately 49% of patients are without PFS events. So a significant advantage for patients treated with Venetoclax-Obinutuzumab. And this becomes more evident when we look at the depth of responses. And we use the level of minimal residual disease in that setting. And we see that now approximately half of the patients still don't have any detectable levels of minimal residual disease after treatment of Venetoclax-Obinutuzumab. So although they are off treatment, they didn't receive any treatment for their CLL, they still don't have any signs of detectable disease in their blood, whereas in Chlorambucil-Obinutuzumab, only 7% of patients do still carry deep responses. And again, when we try to translate that to clinical parameters, we see now that only of those 216 patients randomized to each arm in Venetoclax-Obinutuzumab, only 9 patients have required a next line of treatment. So, and in contrast to that, over 40 in Chlorambucil-Obinutuzumab, which again shows that the patients, when they are receiving this investigational treatment as a frontline regimen, they do seem to benefit from it for a very long time, where they don't need to take any medication for their CLL, which is this very long treatment-free period, which is a very valuable asset for patients with CLL. Well, it might be worthwhile to think about what the next steps are in CLL and where we are going or where we're heading at now that we've seen these results. And I think one of the main or the big next question is, first of all, how to really individualize and personalize the treatment more for CLL patients, because now we are seeing that these new treatment options have efficacy and good tolerability in almost all groups of CLL patients that we usually use to stratify treatment on. So one of the key steps is now to really understand, why do patients, for instance, progress on Venetoclax or after Venetoclax-Obinutuzumab, and which patients are the ones that really have those very long, deep remissions without anything happening? So we need to understand that, and one of the advantages of large trials where we do these regular follow-ups and investigations on MRD kinetics is that we see a broad range of patients and subgroups of patients, and we really can compare these to each other and find distinct characteristics of patients who have a better outcome with Venetoclax or worse outcome with Venetoclax, and try to understand how to improve their treatment. So we know that there are some patients who show a complete remission and with deep response without any detectable MRD already after 3 or 6 cycles of treatment. And we still at the moment treat all patients irrespective of any other characteristic for 12 cycles. So it might be an option that there are some patients don't require 12 cycles treatment. And on the other hand, there might be patients who require more than 12 cycles because they have a particular biological characteristic that we don't know for sure yet. But that means that we need to treat those patients maybe longer or intensify their treatment. So maybe a combination of 2 agents is not sufficient. Maybe we need to add a third or a fourth compound. So this is something that we need to investigate further, and this is something that a lot of clinical trials are working on, trying to really tailor the treatments based on the MRD response and on the individual characteristics of the patients. And at the same time, there's also another big question that really applies to what we have at the moment, which is that we now have 2 treatment options that have been developed subsequently or almost in parallel, which is on the one hand continuous treatment with ibrutinib or acalabrutinib, or in the near future maybe also zanubrutinib. So BTK inhibition taken until disease progression. And we see that some patients take these drugs for 5, 6, 7 years and have a good disease control, but we don't know whether they really need to take this treatment for such a long time, because in this period of time they're also at risk of developing any toxicities of the drug, any drug interactions, and so on. So the question is, do we need to have such a long treatment? And we are accepting this long treatment simply because we know that it has high efficacy or higher efficacy than we've seen before. And on the other hand, we do have now treatment options like the one in CLL14 with Venetoclax-Obinutuzumab that is taken for a fixed duration and allows a long treatment-free period. But we don't know if it has the same efficacy as continuous treatment. So the next question that we will also be addressing with the successor trial of CLL14, which is CLL17. In that trial, we will compare these 2 treatment paradigms of continuous ibrutinib to fixed duration Venetoclax-Obinutuzumab, and also in a third arm, a combination of Venetoclax plus ibrutinib. So a solely oral combination, both also as a fixed duration approach, and to really see whether we have similar efficacy and outcomes with fixed duration as well as with continuous treatments. And maybe this will also allow us to understand which subgroups maybe benefits more from a fixed duration approach, but also which subgroups might benefit more from a continuous treatment approach, and thereby we will be able to even improve our treatment strategies for our patients even more and really continue to improve the outcome of our patients.